Hello friends, welcome to the show Talk with your Doc. Colorectal cancer incidence is increasing day by day. Every day in my practice I see quite a few positive biopsies for colorectal cancer. After the skin cancer, the colorectal cancer is the third most common type of cancer detected in North America. In man, 1 in 23 men will develop colorectal cancer, while in 1 in 23 women will develop colorectal cancer. In 2016, there are 50,000 deaths reported due to colorectal cancer in America. So we can see that colorectal cancer is quite a significant disease in our society, and the incidence is growing up and up. With me today is Dr. Harshad Telang. He is a surgeon at Thunder Bay Regional Health Science Center, and today we are going to talk about the colorectal cancer disease. Welcome, Dr. Telang. Thank you for coming.
Thank you very much
for having me. Really appreciate your time. We see a lot of patients with the colorectal cancer, and what do you think, what are the causes possibly leading to increase in the incidence?
We see a fair number in certain populations, as well as probably dietary habits also have a significant factor. More recent work is showing that red meats such as beef, lamb, etc. increase the risk of developing colon cancer.
So what do you think, what happens when we eat red meat or beef diet? What are the changes in our body which leads to the colorectal cancer?
Personally, I'm not 100% sure, but it has to do something with the breakdown products of the meat in
some
the colon.
Sort of chemicals which are produced with the breakdown of the meat can lead to colorectal.
Yes.
So do you think that meat consumption reduction will reduce the incidence of colorectal cancer?
I think it will definitely help, yes, absolutely.
Yeah. And what are the other factors other than the diet? So meat diet, so what can we replace it with? Like if we don't want to eat meat, then...
Well, everybody's worried about protein.
Protein, yes.
Without eating meat, but there's many vegetarian options that supply adequate protein, so that's not really a big concern. So I think a well-rounded diet, and I don't think you have to cut meat out completely, but minimize it as much as possible.
Especially red meat or beef diet, which is increasing the colorectal cancer.
Yes.
So more fruits, more green vegetables
Absolutely.
will be definitely should be more component of the diet.
Yes, more roughage, more dietary fiber. Has been shown to potentially be protective against colorectal cancer as well.
Right. What about the family history of colorectal cancer? If my parents have a colorectal cancer or somebody, what are the chances of me getting the cancer?
So the risks are increased with first degree relatives. So if your father or mother or brother or sister, or even if your children have had colorectal cancer, then your risk is increased. And it's also increased if there are multiple extended members. So if your father or mother didn't have colorectal cancer, but your mother's sister and her brother and her grandmother, or her mother, your grandmother, had colorectal cancer, then your risk of colorectal cancer also is increased.
So what transmits this? Like what are the genes or what are the factors which leads to the increase in the colorectal cancer incidence in the family? Is there some sort of genes being transmitted for the colorectal cancer?
There's definitely a genetic component to it. I personally don't know exactly what genes are involved with the familial part, but the genetics clinic at the health unit would get involved when there's multiple family members with colorectal cancer and be able to advise patients on their risk.
Right. So as I understand, if our family history, first degree family has a colorectal cancer, then I should take a precaution to reduce the incidence of colorectal cancer in me. So how do I do that?
So if you have a first degree relative who's been diagnosed with colorectal cancer, then the recommendation is that all of their first degree relatives should have colonoscopies at the very latest 10 years before their age of diagnosis. So for example, if somebody was diagnosed with colorectal cancer at age 60, then all of their brothers, sisters, and children should have colonoscopies by the age of 50, if possible.
10 years before the diagnosis of...
Yes, or sooner, but 10 years at the latest.
And then how often I have to get it done then?
So at this point, the recommendation is every 5 years.
Or every 5 years if I have a family history?
Yes, as long as there's nothing found. If there's something found, then it's different, and then it changes.
Changes, right. So family history, the diet, what are other possible risk factors you think is leading to colorectal cancer disease?
Some heritage also has a factor in it. For example, African American populations are known to have an increased incidence of colorectal cancer, as well as certain Jewish populations, namely the Ashkenazi Jews have increased risk of colorectal cancer. Other factors would be patients who have other more immunosuppressive type of illnesses, such as long-term problems with diabetes or other diseases that affect their immune system. Can also not cause it, but may help
predispose.
And make it worse.
Right. How about smoking? Is smoking related with colorectal cancer?
There's some association, absolutely, between smoking.
Alcohol.
Yes, excess
so
alcohol
reduction in the
consumption
smoking will also reduce.
Definitely.
Right.
Yes.
Is there any geographic distribution? Like I was practicing in India pathology, I found that incidence of colorectal cancer is low in the Asian continent as compared to the America. What do you think? Is it your experience or?
Well, I personally have never practiced in India, so I can't say firsthand of working in Asia, but we know from studies that there's a higher incidence of colorectal cancer in North American populations as compared to African populations. And that is thought to be, for the greater part, related to their diet and low meat and very high fiber diet.
Right. So when the people from low incidence move to high incidence, their diet changes, the lifestyle changes, and that leads to the increase in the incidence of colorectal cancer.
Absolutely. East Asian patients, or not patients, but people who move to North America have then developed similar higher incidence of colorectal cancer.
Because they adapt to lifestyle and the diet related, which leads to increase in the incidence of cancer.
Yes.
Right. Thank you so much for sharing with us. We'll take a short break and we'll come back to you after the break. Thank you. Welcome to the show Talk with Your Doc. With me is Dr. Harshad Telang. He is a surgeon at Thunder Bay Regional Health Science Center, and we are talking about the colorectal cancer. Thank you so much, Dr. Telang, for enlightening us about the various causes of colorectal cancer and why the colorectal cancer is increasing in our society. Please tell us, what is the initial disease before it becomes the cancer in the colon?
So the colon usually goes through a transformation from normal tissue to polyp to cancer. And what we try to do is we want to find it at that stage before it becomes cancer and deal with it at
early
the polyp
stage diagnosis, right?
Exactly.
So polyp stage is the early stage of the cancer, which is like a curable stage of cancer probably. But what are the different types of, like when you send us, like as a surgeon, you send us the polyps, and we get some good polyps and few bad polyps. Good polyps we call it as hyperplastic polyp, and the so-called bad polyp we called it as adenomatous polyp. So please tell us about what are the chances of different polyps becoming cancer.
So hyperplastic polyps have pretty much zero chance of turning into cancer, and so if we find those, we get them checked, and if somebody like yourself tells us that that's what they are, then we don't worry about it. The adenomatous polyps have precancer type potential, and so it all depends on the type of polyp and the size of the polyp as to their cancer potential. But any adenomatous polyps we want to remove.
Remove completely. So how do you remove those polyps? What procedure do you do to get the polyps out of the colon?
So there's two ways to remove a polyp. One is by colonoscopy, and then two is by surgery. So if at all possible, we try to take it out with a colonoscope, so that way it avoids an operation. So what a colonoscope involves is it's a very long tube which gets advanced up the colon, and with it we can visualize the entire colon and part of the small bowel if necessary, and if we find any polyps we can take them out with instruments that we can advance through the colonoscope.
So colonoscopy is a procedure by which you can examine the GI tract, and if there is any bumps or lumps, you take a biopsy, or if there is a polyp, you take out and send it to our pathology lab.
Yes.
Now, how often one should get this colonoscopy done?
So the interval and the age at which it should be done vary depending on patient factors. So if you're a member of the general public without any history of colon cancer in the family and no worrisome symptoms or anything, then you should have your first colonoscopy after the age of 50, because we know that the incidence of polyps rises.
So no family history, first colonoscopy at the age 50. Okay.
And then if you do have a family member with colon cancer, like we discussed, then you should have your colonoscopy either at the age of 50 or earlier if it's within 10 years or more from the age of diagnosis.
Okay.
So for example, if your mother was diagnosed with colon cancer at age 55, then you should have it at 45.
Okay. So 50 years of age, I don't have a family history of colorectal cancer. I get my first colonoscopy done and everything is normal. When do I come back for the next colonoscopy?
10 years.
Okay, every 10 years.
Yes, until age about 75. After 75, there's no need to do any further screening colonoscopies.
Okay.
It's different for symptoms, but for pure screening purposes, there's really no benefit.
So 50 years and then every 10 years. And if the family history of colorectal cancer, then first before the 10 years of diagnosis of the family with the colorectal cancer, and then how often we come back?
Every 5 years.
Every 5 years. So
Yes.
it is more frequent than the normal population.
Yes. And then there's one other incident, or one other patient population that we also are interested in doing screening colonoscopies, and those are firefighters.
Firefighters.
So firefighters have an increased risk of developing colorectal cancer
really?
because of their work exposure to carcinogens.
Wow.
And the recommendation is that they should have their first colonoscopy after about 20 years on the job,
Oh.
and then every 5 years or so after that.
So there's occupational exposure
Exactly,
hazard
yes.
to them, right? Now, this colonoscopy can help us to diagnose polyps or diagnose the cancer at early stage. What are the other tests we can do to diagnose colorectal cancer at the early stage? What are the other investigations or laboratory tests can be done?
So there's a couple of different tests. So with regards to looking at the colon itself, if you don't want to do a colonoscopy, there's two other avenues. There's a barium enema and a CT colonography.
Oh.
Both of them are radiologic tests which look at the bowel through imaging. But if anything is found, a colonoscopy has to be done because they can't do any treatments.
Okay.
Other tests as pure screening tests for general populations are stool testing for fecal occult blood, the FOBT test, which is what's available right now. But as of next fall, there's a new test which will be the FIT test.
What is FIT test?
It tests for actual immunohistochemistry, and so it's much more accurate at finding polyps in the colon.
So in that, do we have to do biopsies, or how do we do that FIT test?
The FIT test is similar to FOBT. It's still a stool sample,
test. Okay.
but it's just one rather than three. And if it comes back as positive, then you move on to a colonoscopy.
Okay. So first investigation is colonoscopy. If somebody doesn't want to do, then you do barium enema or CT guided colonoscopic procedure, and other is stool positive test, guaiac stool test.
Well, the stool testing should be done by everybody over age 50 every couple of years.
Okay.
And then if it's positive, then colonoscopy should be done. But for general populations to do a colonoscopy, that should be, as long as it's normal, every 10 years, but the stool testing should still be done every 2 or 3 years.
Now in the stool test, what do we detect exactly? Like, is that blood in the stool we are detecting, right?
Yes.
So who gets this blood positive in the stool?
Well, with the new test that's coming out next year, it's much more specific for colon polyps.
Okay.
The test that's available now can be positive from any source of blood.
Any source of blood, right? So this new test, FIT test, will differentiate between the bleed due to colorectal cancer and that due to other diseases?
Yes.
Okay. That's good. So anybody over the age of 50 should get stool testing for blood
Yes.
every 2 years, colonoscopy after 50 years, every 10 years, and any other test other than this you recommend?
No.
No, that's it, right?
Yes.
Okay, so after this screening, if the biopsy is positive, then what do you do?
So if it comes back as a cancer, and it all depends on what
What
the
type
specimen.
of cancer it is?
Yes. So if it's just a polyp and the cancer is contained in the polyp, we get the report that says that the stalk is clear. So if you imagine like a mushroom with the cancer in the top and then the base of it is clear, then typically we don't need to do anything other than more frequent colonoscopies.
Follow, right.
But if there's concern that the entire polyp is cancer, or if you see an actual cancer, then the next step
Further
is
the
operation.
treatment. Thank you so much. We'll take a quick break and we'll come back. Thank you. Welcome back to the show Talk with Your Doc. With me is Dr. Harshad Telang, and we are talking about colorectal cancer. We just talked about various risk factors, what are the tests done to early diagnose the colorectal cancer, and once the biopsy of colorectal cancer comes as positive, then only I come know that I have a cancer. But before doing the biopsy, before doing the colonoscopy, what are my signs and symptoms which tell me that I might have something abnormality in my body?
So unfortunately, most colorectal cancer patients don't know that they have cancer, and that's the problem, is that a lot of patients will show up when it's beyond the truly curable stage, and then we will need to talk about other modalities for treatment. But the most common sign that patients will complain of is bleeding. Would
Bleeding
be
per rectum.
blood mixed in with the bowel movements.
Right.
And then change in bowel habits can also occur as the tumor gets larger and starts causing more problems with passing stool. Those would be the two most common symptoms.
So after age of certain 50 years, say, and if I get low hemoglobin or I find blood in my stool, I should be concerned and
Yes.
approach to the doctor, not ignore that symptom probably.
Yes, absolutely. If your family doctor does blood work and finds that your blood count is lower than anticipated,
Right,
and there's no good reason for it,
right.
then that would be an indication to be not concerned, but be checked out.
Yes, yes. So once I go to the doctor will do my colonoscopy and they will send it to us for the biopsy. And in the biopsy, we may say it is adenocarcinoma or different types of colorectal cancers like carcinoid tumor or GIST tumor or lymphomas. Most common is adenocarcinoma. That's what we see in our practice. What are my chances of survival?
So the chances of survival depend on a few factors, whether the cancer is limited to the bowel, whether there's any spread of the cancer either locally, whether it's spread beyond and to other organs such as the liver or the lungs. So it would depend on those factors. So if it's limited just to the bowel, if it's been completely removed, then chances of long-term survival are very high.
So once I am diagnosed with the disease on the biopsy, for my survival chances to be determined, you might do some scanning procedures like CT scan or PET scan, or what else you do?
So once the diagnosis of colon cancer is made, patients will almost routinely get a CT scan of the abdomen, just to determine if there's any spread of the disease, and to also look at the primary cancer to determine whether any other treatments are needed before surgery.
Okay.
And then after the operation, they will be followed by the cancer clinic. They'll receive they'll be put through other tests, possibly CTs of other areas of the body, depending on the concern for metastatic disease. And they'll also need routine colonoscopies for follow-up to make sure that there aren't any new primaries or the primary cancer hasn't come back.
Nowadays, we see a lot of patients being treated with neoadjuvant chemotherapy even before they are being treated with surgery. And this neoadjuvant chemotherapy will reduce the bulk of the tumor and make the tumor size small, and then we remove by the surgery. So what are the surgical options available for the patients with colorectal cancer?
So with Well, we basically divide it into two parts. So there's the colon and then there's the rectum,
yes.
exactly.
Yes.
The colon is, and they're two totally separate disease entities from a
yes.
surgical point of view.
Right.
Because the colon has the fatty tissue around it, and the rectum doesn't. And so for the colon, even if it's a large tumor, as long as there isn't any evidence of it spreading beyond the cancer itself, even if there's lymph nodes involved, we will proceed to surgery. Whereas with the rectum, if there's lymph nodes involved, if there's any chance of local spread of the cancer, because the pelvis is such a confined space and the risk of not taking it all out is higher, they will undergo neoadjuvant treatments, so radiation or chemotherapy before surgery.
Before surgery, right. So for colon cancer and rectum cancer, there are different surgeries, and the patients also are in the different stages. So what are the surgical options available for the colon cancer surgery?
So for colon cancer, basically it's a colectomy. So
colectomy.
And we label it based on where it is. So if it's on the right side, we call it a right hemicolectomy. If it's on the left side, left hemicolectomy. If it's in the sigmoid, then a sigmoid colectomy. So, but the goal is to take out the cancer, but 10 centimeters or so of normal colon on either side, or 5 at the smallest amount, and to take out the lymph nodes that drain it, because cancer usually spreads through lymph nodes, and so we want to get a minimum of 12 lymph nodes in our specimen to give us an idea of the completeness of the resection and the chance of spread.
So patients are usually apprehensive, what will be my lifestyle after my segment of colon is removed, you know, like say somebody's half of the colon is removed in the surgery, then they have a pouch and they have apprehension about the pouch procedure also. Can you please explain us about the lifestyle changes or morbidity associated with the colectomy?
Sure. So when we're dealing with just the colon part, if we take out any part of the colon, like we discussed, there's really not much of a change. They may have more frequent bowel movements, but there's really no other major impact long term in terms of their bowel
habits. Even though they have a bag attached?
Yeah, so the bag is a different issue. So that is usually only when we have to do rectal cancer surgery. And so if the cancer is very low, down near the anal sphincter muscles, and we can't take out the cancer without the risk of leaving some behind, then we have to take out the sphincters and everything, and then you'll end up with a permanent bag.
Permanent bag, yes.
Other times when we do a low cancer operation and we do the joining, and we might give a bag just temporarily, just to protect where we did the joining part. So
and the life comes back to the normal after the bag is removed?
If it's a temporary bag, we can put it back together.
Yes.
Yes. If it's a permanent bag, then it's there for life.
There for life.
And as you said, most patients are very apprehensive about it, but once it's there, everybody adapts. I haven't had a patient yet who has regretted having to have that operation because it was medically necessary.
Because the life is saved.
Yes.
Now there are other options of radiation and chemotherapy also. So which patients do get radiation after the surgery?
So radiation is limited to basically the area where they can put the beam. So for rectal cancer surgery, it's used much more frequently. Any other type of colon cancer, it's not used very frequently unless there's cancer that has penetrated into the muscle or something of that they can focus the beam on to hit the cells. Chemotherapy is systemic, and so chemotherapy will be used for most rectal cancers and for colon cancers where there's lymph node involvement, or if there's any spread of cancer to liver or lungs.
Metastatic disease, probably, right? And how do you stage this? There is a staging system called TNM staging system. Can you please tell us how do you stage the cancer? Like what stage am I in a disease? So what do you do?
So the staging system is based on 3 factors. One is the tumor, which is the T, so the size of the tumor plus the penetration through the various levels of the colon wall or the rectal wall. N is the nodal status, so whether the lymph nodes are positive, and then depending on number plus location. And M is the metastatic, so it's either negative or positive, if there's 0 or 1.
So my treatment, if I have a colorectal cancer, will depend upon T, N, M, and M stage. What is the size of the tumor, what are the lymph node status, and how far it has spread.
Absolutely,
which will determine whether I need surgery along with chemo or radiation, probably.
Correct, yes.
Thank you so much, Dr. Telang. This is very, very helpful, and I'm sure all the viewers will get benefit out of your time and expertise. We really appreciate it. Next time, we are going to talk about the lung cancer. So please join us with the next Talk with Your Doc for the lung cancer disease. Thank you.